Hey guys, welcome to your intern year of general surgery residency. My name is Brad Hertzler. I'm one of the PGY4s right now. I will be one of your three chiefs next year. You get the honor of waking me out of bed many nights with new consults and whatnot. I want to encourage you to take advantage of this coming year in a great way. For those who are categorical residents, this is a huge opportunity to set yourself on the right trajectory to a very successful general surgery residency, but also a career. And for those of you who are prelims and who are going on to something else, I encourage you to make the most of this year. I think it will be a very great year. We've got a great surgical residency, a great training here. So, first of all, welcome. I hope you enjoy this presentation. This is going to be on the basic surgical instruments. While not a big and flashy presentation, it will be extremely practical to your time in the operating room to know the names of some of the basic surgical instruments. And then I'll touch on at the very end just some general OR etiquette on how to get through the operating room and survive. So the goal of this presentation is just to give you the basic introduction to the names of OR instruments. This is something that surgical technologists, the scrub nurses, go to school for. They have classes and presentations and books they have to read so that they are prepared, and you guys get one single little lecture that I'm doing right now. Why is this important? First of all, it's going to make you look like you know what you're doing. One of the biggest things that will further you in the OR is just having credibility and, frankly, not looking like an idiot. It'll help you to look like you know what you're doing if you can know the names of the instruments. But in general, it'll also increase the efficiency inside of the operating room. If you know the names, you know exactly what you're asking for and what it can be used for, it can help the case to go better. A couple things to note. First, there are many more OR instruments than I am going to show you in this PowerPoint. There are entire books and websites dedicated to instruments. I'm just going to show you the general surgery instruments, just a few of them, but there are specific instruments that you're going to use for the vascular rotations you do. OB-GYN has all their own set of instruments. Orthopedic surgery has a set of instruments they use, urologic, and there's just many of them. So the book I particularly used in developing this presentation is actually found in the library at Mount Carmel Health Science Library, the one on the West Campus. It's called Instrumentation for the Operating Room. It's a photographic manual. It just has a whole bunch of pictures. You'll see some of them that I took photos of. But if you get lost and you need a resource to go back to, this is one I found that's right on our campus that doesn't get checked out often, I've noticed. So, other websites. Where are other places besides this presentation you might be able to go to just in case we don't cover everything and you have other questions or you want to quiz yourself? Three resources I want to share with you. One is Quizlet.com. There's another one on Amazon you can buy. You can also buy, or you can go to slideshare.net. Let's look at those just real quick. This is an example of Quizlets. You can go through different instruments, click on it, and it'll flip over and tell you the name of the instrument and go through a whole bunch of different ones, and you can quiz yourself. And so that's on Quizlet.com. Another one is SlideShare. Here's a presentation I found that shares with you some of the basic instruments. I decided not to use that one in this presentation, just simply because it didn't share as many of the instruments as I thought were necessary. But it's a good one to, again, go back to. It's got nice pictures. Lastly, I'm going to just show you that if you were to go to Amazon, they even have flashcards for this type of thing. If you wanted to quiz yourself, you can get them used, I think, but for $31. I'm not sure anybody's going to buy it, but just know that it's that out there if you find yourself later on in things struggling. So there are other resources you can use. First thing to know, though, when going through this presentation is that different people call the same instrument by different names. And you'll find that every residency, every hospital has kind of their little culture of names. Things that when we've had attendings come from other locations and we ask for a particular resident, they just say, what are you talking about? What are you asking for? And they'll call it by a name that our scrub nurses don't know the name of. An example is something called the Miller blade. I'll show you this. This is just a big ribbon malleable blade, 2 inches in width. And we call it the Miller blade because, frankly, Dr. Miller uses it. But you would never call it that if you were to go to some other hospital, because that's not the name they would use it. But that's what it's commonly known as here at this hospital. So just recognize that. You may have things coming from your own medical school and names that we just don't use here. So let's get going. We're going to go through a whole bunch, and hopefully you can use this lecture as a resource. First thing to note is just some of the different knife blades that are used in the OR. Typically in the OR, there's the 10 blade that is used, which is the largest knife blade you may use. Its similar cousin is just the smaller 15 blade. It's similar in its shape, but just smaller. And as with needles, the higher the number is, the smaller it actually is. So the 10 is the bigger one, the 15 is the smaller one. I've never seen the 12 one used, but in our ORs, there are the 11 blade, which is more used for a stab incision. The 10 and 15s are used for opening midline incisions or general skin incisions. In every OR set, that's basically what I'm going to show you here is the basic laparotomy and laparoscopy trays come 3 different knife handle sizes. A long one here for deep cases, and then 2 shorter ones come in every set. The next thing that comes in every set is needle holders. Maybe you can't see this up close, but you will note that there's 1, 2, 3, 4 different types of needle holders, all different sizes. There's the small, medium, large, and then extra large for the deepest cases. You can ask for them depending on your particular need in each case, but just recognize that there should be 4 available for you. I'm not going to talk about suture. Jim Markman in his lecture talks about some of the different suture, especially as related to closing lacerations. That's something we'll talk about in other forums, but there are various types of suture you can use, but that's for a different lecture. So let's go through some of the pickups. Again, a lot of these you may know, but some of them, frankly, even as we went through as residents, not everybody knew the names of all the instruments. So the first one I'm going to point out is the Addison forceps or Addison pickups. The lay public calls tweezers are really known as forceps or pickups in the surgical field. I will warn you, don't ever say the word tweezers. It will promptly get you ridiculed in the operating room. But here is the Addison forceps. It's this one up here. Let me show you a little more close up. The Addison forceps has a very narrow tooth to it, and it's hard to see in this particular picture, but right here is a rough section that will allow you to pick up your suture or your needle when grasping it out of the skin. And then up here at this portion is a little tooth. There's another one on the opposite side. And so it is specifically used to pick up tissue or skin tissue. It keeps the skin tissue from being crushed if you were to use one of these without any tooth on it. We'll see some of those in just a second. The next one to highlight is something called a Bonnies. Another name for it is the Ferris Smith. In our particular residency, we always call it the Bonnies. It is this one right here. One shown on the side and one shown on the end. It is used, here's a close-up of it, it is a much thicker and wider pickup, it also has a tooth, so it is used to pick up tissue. Specifically in this case, it's used to pick up fascia. And so you'll use this particular pickup called a Bonney when you're closing the fascia at the end of a case. This rough part will help to grab the fascia, but the tooth will especially help you to keep from crushing the fascia and hold it more easily. The rough spot will also, though, help you to grasp your needle. The next instrument to highlight is something called the rat tooth, or the tissue forceps is what it's known. We typically call it a rat's tooth, and it's this longer, skinnier one right here over on the end of all of these forceps. What does it look like more up close? It is longer, it's skinnier. You will notice that it does not have a rough patch right here, so it is not very good to be used when trying to pick up a needle or to grasp something like that, but it is very good at grasping tissue. That's why it's called a tissue forceps. But this little tooth right here looks like a rat's tooth. It's got two little serrated edges that just by what it looks like a rat tooth. So that's where it gets its name. The next pickup I want to talk to you about is something called the DeBakey forceps. Now, in any sort of surgical tray, you're going to find that there's 1, 2, 3 DeBakey forceps. There's a small, a medium, and a large. This one over here we'll talk about in a second. But a DeBakey's forceps are a good general pickup. You will notice that it's got a rough portion in the middle of it. It's nice and thin, so it's good for grabbing tissue, usually deep in the belly, but it does not have a tooth at the end. So you don't really want to use it on skin because this type of forceps typically will crush the tissue. So you use it a little bit more gently, but it's used inside of the belly rather than on fascia or at the skin level, and it's used to grab the soft tissues inside the belly. Now, the next one has an interesting name. We call it Russians. Pass me the Russians, please, or the Russian forceps. It is all of these that have a little bit wider, and then you can see the end is a little bit bulbed. Here is the other smaller one right here. There's a small one and a large one over here. What does it look like up close? You can see kind of how it bulges out here at the end. This one is a more gentle forceps for picking up tissue because of its widened shape, but you notice its edges are a little bit thicker, and so it can be rougher also on the tissue. We typically would use this for debriding out portions inside the belly, for grasping dead tissue that needs to be removed, since it has a wider surface area for grabbing a large amount of tissue, but it also has the teeth for grabbing that and pulling on it fairly sufficiently. You wouldn't want to use this one, though, on, say, a piece of bowel. It'd be a little bit too rough for that. The next one I want to point out is actually our nickname is the All-American, and I think that's just in response to the other ones being called the Russians. The real name that you'll find for this is called a dressing forceps. It is this one over here. What does it look like up close? It's hard to tell how this is different from a DeBakey, but you'll have to trust me when I tell you that this edge here is wider than a DeBakey. And so it tends to be more gentle than a DeBakey when picking up tissue. If you're going to be in Dr. Fernando Aguilar's cases, he loves to use the All-Americans rather than DeBakeys. And in fact, if you ask for a DeBakey, he'll most likely tell the scrub nurse, nope, give him an All-American. Because again, it tends to have a wider footprint and it grasps the tissue in a wider area, but its edges are not serrated and sharp. So it grasps the tissue fairly gently. Again, just kind of showing the difference, here's the DeBakey forceps, which is much more narrow footstep than this All-American, which is wider, probably twice as wide. Let's move on now to some of the scissors that you'll be using in the operating room. The first one is called a Metz, or that's short for a Metzenbaum scissors. That's these three right here. There's a small, a medium, and a large, or a short, medium, and a long one. They all have a slight curve at the end and they're fairly sharp at the tip, although the tip is not what you would describe as penetrating or sharp. It has kind of a dulled tip on it. These are the scissors that you might be using to go through tissue. Especially, you might use these in cases where there's a lot of lysis of adhesions and you have to take down some tissues. You can use this very tip here to very easily spread the tissue and then cut the tissue where you need to in a fairly precise manner. This is in difference to what we call the Mayos, or the Mayo straight or Mayo curved scissors. It's these two down here. You can tell just even by this picture that these two sets of scissors are much thicker and more hardy than the previous mentioned Metzenbaum scissors. Here's a close-up picture of those. This is the curved one, which you can see has a slight curved Mayo, and you might ask for this from the scrub tech by saying, I would like the curved Mayo, please. Or you can have the straight Mayo. Sometimes this is also just simply called a suture scissors. Because this is a much thicker, more hardy scissors, it much more easily goes through suture and can cut thicker tissue. You wouldn't really want to use this one when cutting tissue inside of the abdomen, though. That's where the Metzenbaum would come in. Now let's move to some of our hemostats and our clamps. Everybody's heard of a hemostat. Here I'm going to show you two of them. You'll notice that this one is slightly larger than this one. This is termed a hemostat, and this one is termed a mosquito hemostat. So if you ask for a hemostat, you're typically going to get a large one. If you ask for a mosquito, you're going to get a smaller one. Very literally, back in the day, these were used to stop little bleeders before you could tie them off. Now we use them in a variety of formats, from holding sutures to holding tissues in a variety of ways. Another clamp that I want to point out to you is something called the tonsil or the schnitt. Both of these names are used in our ORs. As you can see, this is a quite long and sharp clamp. It's slightly curved at the end and does have a rough patch at the end. Oftentimes, we don't use the tonsil as much within tissue, although it is good for separating tissues and getting into small spaces, especially in lysis of adhesions, but we will often use this when placing our drains. This easily, after you make your skin nick, can be pressed through the fascia into the abdominal compartment where it can grab a drain and be pulled out. That occurs because of its long nature, but also its sharp edge at the very top. The next one I want to highlight to you is something called the Kelly clamp. That's the name we use here, but if you look it up in books, it's going to be called the Penn clamp. It is a longer version of the hemostat. It is also wider and not nearly as sharp at the top. You can use this when holding some fascia. It doesn't work quite as well in that case, but it can be used for holding suture, fascia, various tissues. It is a larger instrument than a hemostat, and because of that, has some different uses. The next clamp I want to point out to you is something called the Coker. Now, the Coker, or Ochsner, I've never heard anybody use this name, but this is what its actual name is. But we call it the Coker, is an instrument. Right here is the one that is the Coker. A smaller view of it shows that, yes, it does have a rough portion, but it's got these toothed edges that really grab onto tissue. Where the Coker tends to be used is where you want to grab your fascia and elevate it. Either when you're trying to establish pneumoperitoneum and you've made a skin edge and you're grabbing down for the fascia to elevate it to place your Verus needle, or When trying to close up the fascia at the end of an open case, you can grab onto your fascia with one of these on each side, and it will easily hold the fascia while you try to sew it together. An Alice clamp, in difference, is a clamp that has kind of a different head on it. What does it look like? It's got these serrated edges that kind of come together almost like toes right here. An Alice clamp is used in a variety of ways for grasping tissue and holding it, perhaps while you are trying to remove it. Sometimes you might grasp onto a lymph node or how about a section of breast tissue while you're trying to do a lumpectomy. But it is excellent for grasping and holding something and kind of using that as your point and your access while you're trying to bovie that particular portion of tissue out. Oftentimes we'll use these on skin lesions or lipomas. We grab the lipoma and then bovie around it. So it's really oftentimes used to hold a specimen. The next one is called a Babcock. It's this one here. It's a type of clamp that's meant for a much more gentle application. As you can see, the tip is more round in nature, doesn't have any serrated edges, and it looks like tissue could easily kind of come out from it if it's not held tightly, and indeed that is the case. You would use a Babcock to hold gently on to small bowel or large bowel while you're trying to manipulate it, but you don't want to hurt the tissue that could occur if you used, say, of course, a Coker or even an Alice. Excuse me. This is just much more gentle on the tissue and often used with small bowel. A Leahy's or a Leahy's tenaculum is a much rougher instrument. It's this one here on the left with the big teeth. Up close, it looks like this. It is used in kind of a similar way to a Coker. You might grasp fascia, but because of its nature of these big claws coming together, you wouldn't use it at the beginning of a case to grab the fascia to establish pneumoperitoneum, but you might use this to grab the fascia and hold it out of the way, and you know it's not going to let go because these teeth are going to sink in. It's called the Leahy or a Leahy's tenaculum. Another grasper that you may use, or a clamp, is called the right ankle. Every laparotomy set is going to have 3 of these, a small, a medium, and a large. Right angles can be used in a whole different bunch of ways. You'll oftentimes see attendings use a right angle to help develop planes so that you, as the surgical resident, can bovie in between their right angles that expose the tissue to you nicely. The next one I want to highlight to you is something called the sponge stick. The sponge stick is a relatively large instrument. Let's see if I can get a better view of it here with kind of a wide opening. Specifically, it's called a sponge stick because you literally will hold a sponge in it. Now, it can be used without a sponge to debride large amounts of tissue that need to come out of a patient. The last time I used this is when we were doing a laparoscopic splenectomy, and we didn't need the specimen in total, so through an endo-catch bag, we were just morselizing the spleen, and I used a sponge stick to crush the spleen and draw it out. But you can also use it to kind of gently push away tissue by putting a sponge in it, and it holds the sponge very nicely. The next one is called a penetrating towel clamp. It's got these big teeth on it. This is used, I thought I had another picture, but I guess I don't. This is used in a couple different ways. One, very literally, to grab a towel. Sometimes when you're creating your sterile field, you will hold your 4 towels onto the patient by using these clamps, but you can also use them to close the skin out of a port site that's overly generous and is leaking out air. It just makes a small puncture wound in the patient to help keep that port site closed when the air is leaking out. You can also use it to grasp fascia as well. Because of these sharp points, it doesn't crush the tissue at all. It just penetrates and holds deeply. Let's move on to kind of the next section of things, which is our various retractors. This is just kind of a general page in the book I highlighted at the very beginning that shows different types of retractors. Here are some retractors that are actually able to be squeezed and will open up the skin. Here's a variety that are held in one or two hands, some like with a rake, claw, and others much more gently. We'll go through them individually. The first one I want to highlight to you is the Wheatlander retractor, or some people call it Wheaties. It is a retractor, I don't have as close up, but it's a retractor with some claws on the tip that as you squeeze the end part, it retracts and pushes open. You'll use these oftentimes when doing things like open and inguinal hernias to keep the skin edges open. You might also use these on carotid cases, again, to keep the skin edges open and keep your surgical field opened up to you. The next retractor is called a Gelpi retractor, or Gelpies for short. There's not too many attendings who use these. They use them in a similar way to the Wheaties or the Wheatlander retractors I just showed you, but as you'll notice, the retraction is with a single sharp point, and so it tends to be less crushing on the tissue, but does penetrate the tissue, so you do have to be careful with how you use them. The next type of retractors are called ribbon retractors. This actually is an example of the Miller blade that I pointed out to you at the beginning of the lecture. It's just a form of a ribbon retractor where they have a 1 inch, a 1.5 inch, a 2 inch, and a 2.5 inch retractor. I believe those are the sizes. These are malleable and can be bent and used in a variety of ways. Sometimes at the end of the case, we'll put these on the patient, and as we wash out the midline wound at the subcutaneous level, this keeps the water from going all over our feet. Just a simple makeshift use of it. But a smaller one can be used in deep pelvis cases to keep bowel out of the way while you're suturing. That'd be another example of how they're used. Another retractor is called a malleable retractor with handle. As you can see, this one's been bent plenty of times. You can bend it in all sorts of ways at the tip or at the bottom. It has a handle. It's just a retractor that is, as its name says, malleable and useful in various instances. The next set of retractors to highlight has a variety of names depending on who you're with in the operating room. Oftentimes we'll call them Richardson retractors, but the real name of them is an Eastman retractor or a double-ended Richardson retractor. As you can see, each of these have two different ends, and their ends are actually different sizes, and so you can use them to retract in a variety of ways, from the very big ones where you might retract the body wall to the very small ones that you may use at the very end of the case when you're trying to close fascia and you just want to keep the skin edge out of the way while you're closing the fascia. Another name, these are double-handled, but these other ones here that have a single side and have a handle to them, some people also refer to as a Richardson retractor. They're also known as a Kelly retractor. I realize this is kind of a confusing part of the presentation, but all of these retractors in general are generally known as Richardson retractors or double-ended Richardson retractors. But you could use the name Kelly retractor if you wanted to as well. You'll notice that they come in a variety of sizes. This one here, these particular two, I want to point out, these are called by some people appendiceal retractors or long nose Richardson retractors. They are much thinner in size, but also they're rather deep, so they can go in deep but narrow holes in the tissue to kind of retract out of the way. You can imagine this on an open appendectomy case where you don't want to make a big incision, but you do need to be able to get down to the appendix. These retractors would come in handy. The next type of retractor is called the Army Navy. I don't know where the name comes from, but this is a retractor that is double-sided. It has a long flat edge. Oh, I don't have another picture. But, it has a long flat side and a shorter side that can be used in a variety of ways. The next retractor to highlight are these two big ones. These are called Deaver retractors. Again, I know there's a lot of different retractors, but they can all be used in various ways, and you can try them out in various cases. But these ones might be used. You notice they have a real soft curve here. They're not going to be pointy. They're not going to hurt bowel. You can use bowel to retract out of the way. You might be able to retract the liver out of the way with these ones. Now, in the laparoscopic set, all of those come with what's called an S retractor, named simply because they look like an S. These are used deeply within skin edges, but small port sites, maybe to expose the fascia at the very base of a port site that you need to close. These little edges can reach down in there very nicely and help you expose that fascia. They're also slightly malleable, that is, and bendable, so you can get them deeper in there and they hold more easily. The next one are these two right here. They're called vein retractors, or another name is the Cushing vein retractor. It's an instrument that has just a very gentle edge here, and you can kind of imagine that your vein might come right through this edge, and you can retract it gently out of the way to expose tissue underneath. You use this a fair amount when doing Whipples, especially on the portal vein, to pull it out of the way to expose that retroperitoneal margin. Some other retractors are known as the blunt rake retractors. Here we actually have 4 different rakes. Now in this picture they all look the same, but it's hard to tell. These ones here have a much more pointy teeth, whereas these ones over here are much more blunt. These are called the blunt rake retractors, whereas the other ones are called the sharp rake retractors. Why is that important? Well, these can hold tissue out of the way in general, but these can actually penetrate tissue and perhaps lift it up. You'll use the sharp rake retractors often when doing mastectomies and you need to hold up the skin edges. The skin edge would just slip out very easily from the blunt rake retractor, but the sharp rake retractor will hold the skin edge very nicely, and you'll be able to do a very fine mastectomy to remove all the breast tissue off of the skin at the right depth that you need. Another type of retractor is called the Sen retractor. It's this one right here. You'll notice that it's got 3 raked edges, those are down here, and then a more kind of a handle retractor here. This is for much smaller skin edges that you might need to retract and hold. These teeth here are quite pointy though, and will grasp the skin edges and hold them nicely. This Sen retractor looks like this from a different angle. Again, the bent handle over here, but the much more deep toothed retracting portion here can grasp the skin. There's another type of retracting system. It's called the Balfour retractor. As you can see, it's made up of a variety of pieces that can come together. It's got a deeper set, and it's hard to tell on this picture, but this is a shallower set here. These are placed inside the patient, and you can retract this one to the right and one to the left to open up the fascia. Then you can use these particular blades here. They're called this one is called a bladder blade, which, if you can think of it, will fit right nicely onto the bladder and hold the bladder out of the way. This is a retracting system that can be used inside of the belly to retract. I wanted to highlight one other set that you may often be using when you're doing a sigmoid resection and you do your anastomosis through the anal canal up into the bringing a portion of the descending colon to the pelvic brim or the very top of the rectum. You're going to use a sigmoidoscopy set to help blow air into that and to even look in there to view your anastomosis. This is the portion that goes in the anus and into the rectum. This is your trocar that goes through it into the end and then can be pulled out. And then here is your mechanism to blow and insufflate air into the sigmoid to test your anastomosis to make sure there's no leak. These are just to hook it up to the outlet and to provide light inside if you should need that. So you'll use these on sigmoid resection cases. All right, now I want to move into a little bit more part of the presentation that looks at the laparoscopic side of surgery. Of course, if you've done any sort of surgical rotations in med school, which you have, you'll note that there's various type of trocars that are used through which our instruments can go. There's 5 millimeter trocars, there's 11 millimeter, there's 12. They come in a variety, and even with robots, we will use 8s. But these are the normal ones that can penetrate the fascia and go into the abdominal compartment. Here is a different one. I'll highlight that here. This is the normal trocar that is much sharper at the end and can penetrate through fascia, and then this inner cannula comes out and you're left with the trocar through which your instrument goes. But this one here is called a Hasson trocar. Some of our attendings use this, and as you'll note, it's much more blunt here, so this does not penetrate easily through fascia at all. And that's really its point, because you don't want to hit something vital on the other side of the fascia that this one could really poke through. This one has a much more gentle, but this requires the surgeon to open up the fascia with a knife first and then gain access into the abdomen in a more blunt method, and then insert this trocar through that fascial opening. It uses these and sutures that go through the fascia to tie this trocar into place, where it's just simply friction. As you can notice, there's kind of a rough edge here that holds this particular trocar into place. So moving on to laparoscopic instruments. I'm not going to spend a lot of time on this portion of the talk because even when I was looking through the surgical instrument book, I noticed that they had a lot of instruments that I've never even seen or used, and they use names for them that we don't typically use. But just to kind of highlight a variety of the different laparoscopic instruments, from 5 millimeter instruments all the way to 10 millimeter instruments, and used for a variety of things. Here are the most common ones. This isn't the best picture, but this is called a blunt grasper, or the bullet-nosed cup grasper. As you can see, it's got a very rough patch here that mimics that. It's got a blunt-nosed tip here, and you use this oftentimes in surgery doing cholecystectomies, and you'll use this in places where you're concerned about puncturing something. So it's good for grasping off say adhesions and pulling them off of the anterior abdominal wall or off of the gallbladder. As opposed to the Maryland 5 millimeter dissecting grasper, which as you note here has a much more sharp tip, and it can be used to dissect through tissues and open up spaces. Again, you'll use this with cholecystectomies to kind of push through the tissue and open up and then spread the tissue apart that you would never be able to do with this blunt grasper and its tip. Now, this is where the names get a little bit funky. So, in our particular residency, some of the attendings call this the Locky Bitey grasper. I couldn't even find this on the internet. But what this could be used for in cholecystectomies is to grasp the gallbladder and elevate it over the liver edge. It has some teeth here that grasp much more strongly than, say, the blunt grasper, and it's also a locking grasper, so you can lock it in place and just, with a much easier grasp on your hand, push it over the liver edge. The next laparoscopic instrument to highlight that would be used in, say, a cholecystectomy also is called the stone scoop, or some call it the 10 millimeter spoon forceps. 10 millimeter in size, or 1 centimeter, so it requires a 10 millimeter trocar site at least to go through. But as you'll notice, the middle of it is hollowed out. It's used to grasp, say, gallstones or other objects within the belly and pull them out of the belly, and it'll hold on to them very nicely. Another instrument you may use in a cholecystectomy is an instrument called the Olsen cholangiography or cholangiogram grasp. Out of here comes a catheter that can go through a ductotomy, that is, into the cystic duct where you make a hole, and you can put this catheter that comes through the handle all the way into that cystic duct, and then you can shoot contrast and get a cholangiogram. This portion of the grasper will then grasp onto the cystic duct and hold this catheter in place. How might this be used? Here's an example of the Olsen cholangiogram clamp being used. Here's your ductotomy, and here is this catheter that's coming out. I don't know what it's doing on this adhesion here, but it will go into the cystic duct, and then these clamps will go around the cystic duct and hold it in place while you do your cholangiogram. This is as opposed to another type of cholangiogram catheter known as the Kumar catheter. Dr. Dabbs uses this one in his practice more than the Olsen cholangiogram catheter. As you can see, it has these big graspers here, and out of the side of the laparoscopic instrument comes a needle through which your contrast goes through. So you grab the infundibulum of the gallbladder, you grasp it off, and you're actually cutting it off from the rest of the gallbladder, and then you can fill this area and then hopefully your cystic duct and your common bile duct with contrast and perform your cholangiogram in that way. So this one's called the Kumar catheter. A couple other laparoscopic catheters, graspers that will be used by various attendings. This one's called a Hunter's. It's hard to tell, but this one's different from a blunt grasper because it's around twice as long. A blunt grasper is about only this long right here. The Hunter's is much longer, so its surface area is longer. Anytime your surface area is wider, it's going to be a more gentle grasper. These ones are good for grabbing bowel laparoscopically if you need to run the bowel in a laparoscopic case from beginning to end. Dr. Paget will often use these in his bariatric cases. Another type of grasper is called a wavy grasper. In various textbooks or in various manuals, this is known by other names, but this is what we call it, simply because, as you can see, these teeth, they're not sharp at all, they're just wavy, and they coincide with the teeth over here. This also is good for grabbing tissue inside the belly in a fairly gentle way. Other laparoscopic instruments are highlighted on this page. Some of these you'll use often and others you won't. These are suction irrigators that come with every set. These are suture passers. The only time I've ever used this is in my FES, FLS, Fundamentals of Laparoscopic Surgery, where you'll have to do that sometime in your second or third year as part of your process of being trained to be a general surgeon. I've never seen any of my attendings use them here at Mount Carmel. Other laparoscopic instruments include a hook Bovie electrocautery, which we'll look at next, or a spatula electrocautery. Here's what a hook Bovie electrocautery looks like. The tip is literally a hook, and it's hooked up to the electrocautery machine, and a monopolar signal comes out of this and can be used for coagulation and for tissue separation. The spatula tip electrocautery is a long instrument, as all laparoscopic instruments are, but the end of it is literally a spatula. You can't grasp any tissues with this, obviously, but you can use it in a wider fashion to achieve hemostasis on the liver bed, for example, or to take the gallbladder off the liver bed. Again, a number of other laparoscopic instruments are shown, some of which I have never even used here at Mount Carmel, such as this one, E. I want to just show you one single page of robotic instruments. We have just developed this year a robotic curriculum so that every general surgery resident, if they desire to go into general surgery, will be able to be certified in robotic surgery. It's just good to know some of the instruments that may be used. I'm going to highlight just a couple of them here. The first one is A, which is a needle holder. Not a specific name, but you'll use this often for throwing your robotic sutures in a variety of cases. The other one I want to highlight here is B. This is called the Cadier. Cadier is the name. It's a French name, but it's good for grasping tissue and holding onto it in a very gentle way. Dr. Paget and many of the other robotic surgeons use the Cadier frequently when holding tissue. Other robotic energy devices that may be used are sometimes these Maryland bipolar forceps. They can be used to spread tissue, but then also to cut it. You may use the monopolar sharp shears, which have an energy that goes through them so that as you're cutting, yes, it does it sharply, but it also coagulates the tissue. And lastly, I oftentimes will see attendings use the hook monopolar cautery when dissecting through tissue. All right, so at the end of your case, now you're done with all your laparoscopic dissections and your case, you have to close up the port site. Oftentimes, we'll use something called a PMI suture passer, which stands for, that's just the name of the company, Performance Medical Inc., which is a long, sharp tipped device that has these graspers in it that when you push down, the graspers come out, and you can put a piece of suture in there and push the suture through the fascia and then grasp it and then push through another portion of the fascia, grab your suture and elevate it, and it will close the port sites at the fascial level. Another possibility to use the port for port site closure is called the Carter-Thomason. It's a more expensive option, but it certainly is easier and makes your fascial closures very precise. Dr. Keith uses this one when closing up the fascia. It involves a needle that, just like the one previously shown, the PMI previously shown, has a little pin that you push down. It displays some graspers here that hold onto your suture, and then you put them through these side ports here, and it goes through the fascia in a very specific location. That's called the Carter-Thomason. Here's an example of it being used where you push down this needle, which is holding your suture, and you've already done it through this side, and then you can grasp it and hold it up, and it will close your port site. All right, that's a lot of OR instruments. I appreciate your patience as we've gone through that, but hopefully this will help you to go through and remember the names of a variety of instruments in the OR. I do wish I had had something like this during my first year of surgery training. Lastly, I want to just now end with a few slides on OR etiquette. The first thing to know about the OR is, yes, you are the surgeon, and so because of that, it is your room in the way that you're kind of the captain of the ship. But at the same time, it's not your room. This is the room of your patient. This is the room of your scrub tech and your circulating nurse, of the anesthesiologist, and all the other people that are in there. And so the days of where the OR was controlled mightily and powerfully by the surgeon have gone by, and a much more teamwork-orientated view of the room has come into place. Yes, you do lead the ship in being its captain, but realize that you're part of a wider team that functions in the OR. So what do you do first when you get to the room? It's going to be vitally important during your intern year to introduce yourself to everyone you can in the operating room. You need to get to know them. You need to know them by name. And if you don't, go ahead and ask them what their name is. Yeah, you're going to forget a lot, and you'll have to ask a second time and a third time, but this will help you out a lot in the future. People feel respected when you know their name. The second thing you need to do when you get in the room is take off your name badge and off your phone and place them on the counter or in a place where the OR staff, specifically the circulating nurse, can see it and then know what your name is, because she has to log that down to know who is in the operating room, but also so she can respond to your pages excuse me, while you're scrubbed into the case. The next step then is to get out your glove sizes, whatever those may be, your single glove or double glove, and then get out a gown and hand them to the scrub tech so that you're ready to go when the case gets started. The next thing that you'll do then is, after you've handed your gown and gloves to the scrub tech, you're going to get ready for the case by going out and washing. Hopefully this is old hat to most of you, but you should know that if you are visibly soiled, like, you've been working out in the yard during the course of a weekend. This happened to me this weekend. Hands are dirty. There's some dirt underneath your fingernails. You have to use the water and the sponge scrub. If you're visibly soiled, you cannot use Avogard. Now, if you've already done your first scrub of the day or your hands are not visibly soiled, the American Board of Surgery is saying that now Avogard is okay for your first scrub of the day, as well as any subsequent scrubs. Avogard is the particular product we use here at Mount Carmel, and here's an example of what it looks like. Then you'll go into the room, and the scrub tech will gown and glove you, but if the OR is busy and you've asked permission, you might go ahead and gown and glove yourself. It's okay to do that as long as the scrub tech gives you permission to grab the gown and gloves off of her setup table. The circulating nurse is another nurse in the room who is not scrubbed in, but the circulating nurse has a very important job. Yes, she's in charge of charting and orders and getting supplies, but she's also in charge of OR sterility. If she calls you out on something and says that something is not sterile, or you need to change your glove, or you touch something that you shouldn't have, or you scrubbed in a wrong way, it's going to be your first inclination to argue. But I want to encourage you, don't argue. It's her job to see where there's sterility and where there might be violations in that. And it's your job to make the necessary changes to act in accordingly. I realize some nurses may want to just kind of make you feel like they're in charge and you're a lowly intern. If that needs to be the case, then let it be the case. Go ahead and do what they've told you, re-scrub or get a new gloves or whatever it need to be to make sure that the circulating nurse has control of the OR sterility. A word on Mayo stands. The Mayo stand is the name of this particular tray that every scrub nurse has at the operating field. It is all of the instruments that are currently being used in the operation. They will have their back table, which has many more instruments that can be used by turning around, but these are the ones that are right there. I want you to think of this as being owned by the scrub nurse. This is not your table. This is not for you to lean on. This is not for you to grab anything from. They organize this table in a very specific way so they know exactly where instruments are when they're called for. So if you want to grab something off this table, make sure you ask permission. There are a few scrub nurses here who will slap you if you try to grab something from their table, and maybe rightly so. I like to think of this as they own this table. Now, a couple words on OR etiquette during the case. Make sure you're communicating with the scrub tech. It is our job to make sure that people in the OR are kept safe, that nobody is punctured by a needle, nobody is stabbed by a knife, and so make sure you're communicating. If you lay down a needle or a knife or a suture on the mayo or on the legs of the patient, communicate that to the scrub tech by saying needle down or knife down, or at the beginning of the case, how would you like me to hand this instrument back to you? Some like to have it handed hand to hand. Some like to have it laid down on their mayo. Each scrub nurse has their particular ways that they like it. So make sure you just communicate. Never ever throw down instruments or throw the needle back to them or the knife back to them. Every once in a while you'll see this displayed poorly by some of the attendings, but this is never the right way to go about your time in the operating room. This is not a TV show where we get to act however we want. It's our job as surgeons to keep people safe in the operating room. Some other things, be helpful in the OR. If the patient needs to be moved from the gurney to the bed or to the operating table, help them move. If they need to be moved back at the end of the case, help them move. If a towel needs to be got at the end of the case or some suture needs to be retrieved, see if there's any ways that you can help out. Again, while you are the captain of the ship and the surgeon in the room, it's also a teamwork mentality nowadays. So be helpful however you can. Second thing, or the last thing is, when it's time to leave the room at the end of the case, make sure you ask permission to leave. The scrub nurse or the circulating nurse may be the only nurses in the room to help move the patient. Maybe it's after hours and there's no other people that can come help move. So ask them before you leave, will you need help moving the patient before I go do orders? Make sure you communicate with anesthesia. Are you okay with me leaving to go do orders? Some of the anesthesiologists want the operating surgeon to remain in the room while the patient is waking up to make sure nothing goes wrong. So just make sure you're communicating these things in the operating room. It's really not that hard. Just be nice, don't be a jerk, lend a helping hand, and you're going to have a very successful year. All right, that's been a long presentation. I appreciate your patience. Hopefully this can help you as you get into the OR to look like you know what you're doing and to have a very successful time there. I think you'll find that this is going to be an exciting year. I encourage you to make the most of it. And just know that myself and the other chiefs always have an open door. We would love to hear from you if you have questions or concerns about anything. It's our job to be here to help you get the most out of this year and out of your surgical training. All right. Thanks a lot. Back to work now.